Hello, everyone. We are Samar and Farheen, and we'll be presenting a case seen at the Corewell Health Dearborn Emergency Department. So, our patient is a 35-year-old female who presented with a 2-week history of abdominal pain associated with nausea and vomiting. The pain was mostly in the right upper quadrant, although at times it started in the epigastric region and radiated to her back. She reported that the pain worsened after meals, although it was not linked to any specific trigger foods. Over the past week, her symptoms have noticeably worsened. She recalled having a similar episode last year, but it was less severe and resolved on its own, so she didn't seek any medical care at that time. On exam in the ED, her abdomen was tender to palpation. And then in terms of her review of systems, she denied weight loss, fever, chills, or fatigue. The only positives were abdominal pain, nausea, and vomiting.
Her past medical history is notable for sleep apnea, obesity, and hyperlipidemia. Her only past surgical history was a wisdom tooth extraction. She is not currently taking any medications and has no known allergies. In terms of family history, her mother has thyroid disease and fibromyalgia. She does not use tobacco or drugs, and she drinks alcohol socially.
So on arrival, her vitals were stable. Her temperature was 37 degrees Celsius, blood pressure was 123 over 83, heart rate was 87, respiratory rate was 18, and oxygen saturation was 100% on room air. Her BMI was 38.7. Her labs did show mild transaminitis with an ALT of 86 and an AST of 111. Alkaline phosphatase was slightly elevated at 114. Her total bilirubin was normal at 1.0. Lipase was normal at 33, and a pregnancy test was negative. Her last menstrual period was in March 7th.
So, based on this information, we developed our differential diagnoses, the first of which is symptomatic cholelithiasis. This was considered because her pain fits the classic biliary colic pattern with right upper quadrant pain that worsens after meals associated with nausea and vomiting.
Our second differential was choledocholithiasis. Choledocholithiasis is basically stones in the common bile duct. It usually presents with jaundice and abnormal cholestatic liver function tests. Our patient had a normal bilirubin and no jaundice, making this less likely.
Our next differential diagnosis is acute cholecystitis. Acute cholecystitis occurs when there is persistent cystic duct obstruction leading to gallbladder inflammation. Patients typically have prolonged pain lasting over 6 hours, fever, and leukocytosis. None of these symptoms were present in our patient.
The next differential is ascending cholangitis. Ascending cholangitis presents with Charcot's triad of fever, jaundice, and right upper quadrant pain, often accompanied by sepsis. Our patient did not demonstrate any of these features.
Our next differential diagnosis is pancreatitis. Pancreatitis was unlikely here given her normal lipase levels and absence of typical severe epigastric pain radiating to the back.
And then lastly, we have pregnancy, but this was ruled out with a negative HCG test.
For imaging studies, the first one they got was a right upper quadrant ultrasound, which revealed multiple gallstones, with the largest measuring 1.3 centimeters in the gallbladder neck. So the right upper quadrant ultrasound is the picture on the left, and within the right highlighted circle, you can see some white hyperechoic structures within the gallbladder indicative of the gallstones. And then they also got a CT abdomen and pelvis, which confirmed cholelithiasis without any evidence of acute cholecystitis. You can see this image on the right, and again, within the highlighted circle, you can see some white structures indicative of gallstones within the gallbladder. So, based on this information, we developed our final diagnosis.
Our final diagnosis is symptomatic cholelithiasis. So, for the pathogenesis of symptomatic cholelithiasis, it basically starts out with the formation of gallstones. Gallstones form when bile becomes oversaturated with cholesterol, bilirubin, or both. When a stone temporarily obstructs the cystic duct, it causes increased pressure in the gallbladder, leading to pain. Importantly, this does not involve any infection or significant inflammation. So in the picture on the right, we can see how there are stones that are forming in the gallbladder and they're causing some irritation. One of these stones is pictured blocking the cystic duct, and this is the cause of the painful symptoms that the patient feels.
Classic symptoms of symptomatic cholelithiasis include biliary colic, which is colicky right upper quadrant pain that can radiate to the right shoulder or back. The pain is often worse after eating fatty meals. It can last from 30 minutes to several hours, and the pain may resolve on its own. It is often associated with nausea and vomiting, but unlike cholecystitis or cholangitis, there is no associated fever and jaundice.
Usually, the diagnosis is made based on the history and physical exam, as well as ultrasound findings of gallstones without wall thickening or pericholecystic fluid, which is basically the images that we saw on the previous slide. Labs are usually normal or only mildly abnormal.
The definitive treatment for symptomatic cholelithiasis is an elective laparoscopic cholecystectomy. In the meantime, conservative management can include dietary fat restriction, NSAIDs for pain relief, and in select cases, medical therapy such as ursodeoxycholic acid for cholesterol zones. Given our patient's recurrent symptoms and imaging findings, it was ultimately decided that she would get a laparoscopic cholecystectomy, which was scheduled for the following day. The procedure went well, and she did good after the surgery as well, and she was discharged soon after.
So these are our references, and thank you so much for listening to our presentation.